Okay, here we go with the final part of this series on restraint and behavioral emergencies, and let's get right to it. So here are our objectives for this segment of the video series. We're going to discuss methods of restraint and select appropriate pharmacological agents. We're going to discuss some tactical considerations. We're going to differentiate between safe and unsafe packaging or transport of these patients, and hopefully avoid some common pitfalls that we see pop up in the news and other case reports and M&M series every now and then. So, let's talk about some tactical considerations. The first thing is what I like to call the search rule, is that not all searches are created equal. And the officer will tell you there's a difference between the search they do when they first get on scene and they aren't sure if somebody's a suspect or just an innocent bystander versus the one they do before they're about to arrest somebody versus the one they do when they put them in the car or they take them out. And a lot of times when we become involved, they haven't been thoroughly searched, even though they may have been searched. So I think it's useful to ask officers if they've searched a person, but we shouldn't take it at face value. There's tons of stories about people who've been in handcuffs even and have had large caliber full frame handguns on them. So keep that in mind, that if you take somebody in the back of your ambulance, make sure that they have been properly searched if as concerned. Make sure that their handbags or their backpacks or their grocery bags that they keep their belongings in are out of reach and are safely secured. There's the +1 rule as far as weapons. If you find a knife or you find a handgun or somebody's found a handgun or a knife on a patient, you need to assume that's not the only weapon. So if you find one, assume there's one more at least. It's very common for people who, especially people who practice EDC, which is everyday carry. If they're going to carry a knife or a handgun, they're going to carry a knife. If they're going to carry a knife, they may carry a pepper spray or mace, or they may carry 2 knives, or any number of different things. Let's talk about locations. Bedrooms are bad, kitchens are bad, garages are bad. Kitchens and garages are bad because they have lots of nice, sharp objects. Bedrooms are bad because you are invading somebody's most private of spaces, and as a general rule, that heightens tensions, puts people on the defensive. There's a situation I like to call the Kramer corollary, that if somebody's sitting on a couch, beware of what's in those couch cushions. One of our former medics had a guy pull out a large caliber hand cannon out of the couch and trace it across him. I would also beware of confined spaces and nearby furniture. Now, when I say confined spaces, I'm not talking about the industrial type of confined spaces. I'm talking about the confined spaces caused by cluttered furniture, overpacked residences, and hoarders. As you move close to patients, depending on the environment you find them in, you may not have much room to get into a nice, to extricate yourself easily. So keep that in mind, especially if it's a tight space like a bathroom or something like that. If possible, try to approach a patient at a 45 to 90 degree angle. This way, if they decide that they want to attack you, they have to turn before they actually move toward you. And this will buy you a half a second to a second. And that may make a significant difference when it comes time to escape or evade or practice some self-defense. Always keep in mind that distance from the patient equals time to respond safely. The further away you are, the more time you have to defend yourself or to move away. However, also keep in mind that the further away you are from the patient, the less ability you have to assess them. So look for the balance. There's also something called the prison crouch or the prison squat, or sometimes called the Slav squat. And this looks like a very submissive position where somebody's crouched on the ground, but what it actually does is it gives them a lower center of gravity and a larger lunge distance. Again, another reason to approach at a 45 to 90 degree angle is in case they decide to lunge out and take you to the ground, you have a better chance of avoiding that. And here are some examples of what I'm talking about. This doesn't look threatening at all until they lunge out at you of their body height, 4, 5, 6 feet further than you would expect, and take you off at the knees, and then it's a ground fight you don't want to be in. Also consider some other contributing causes and factors for their agitation and see if you can mediate them. So here are some of the big ones. Did they acutely change from normal and healthy? Why was that? Did their medications change? Do they have an organic brain disorder such as dementia or Alzheimer's? Is it getting worse? Maybe that's the cause for their agitation. Are there other health-related causes? Opioid withdrawal, alcohol withdrawal, post-ictal period, hypoglycemia. Any psychosocial causes. In other words, they may have a pretty strong mental health issue or history, and has something changed? Has their medications changed? Has their life situation changed? Many people with severe mental disability are really functioning at the top end of their resources to deal with their daily life. And sometimes a subtle change, such as a change in living environment, a change in roommates, a change in job situation, can really become overwhelming and contribute to their issue. Environmental causes. This is everything from toxicological reasons to just overstimulation. Is the TV blaring? Are the lights really bright? Is there a lot of yelling going on around? Stuff of that nature can all contribute to a patient's anxiety and combativeness. This is why a lot of patients get better when we put them back of our ambulance. And finally, unskilled caregiving or unskilled care by healthcare providers. Make sure that it's not paramedic-induced, nurse-induced, so on and so forth. And when I talk about this, I'm really talking about making sure that we or the other providers aren't agitating or escalating the situation. Being overly authoritarian, making gestures, being overly rough, taking a blood pressure without asking, letting them know what's going to happen first. All these can really escalate the situation, escalates the patient's mental distress. And this is what we want to avoid, is we want to avoid them going all hulkish on us. So here's some other assessment cues. Keep in mind that 30% of these patients getting violent with us are going to be toxicological in nature. In other words, it's going to be drug-induced, methamphetamine, bath salts, etc. 33% are going to be psychological in nature. It's purely related to a mental health issue. And 33% going to be organic, secondary to maybe an old head injury, a brain lesion, post-ictal period, hypoglycemic, something along those lines. Don't assume it's just a psychological emergency. This is also pretty important. We go to select the agents that we are involved, the drugs we might use to help calm them, and we'll talk about that in a little bit. I also want to point out that these are just very rough numbers based on hospital admissions. I would be willing to bet that we see a large proportion that are multifactorial. They're both psychological in nature and they are consuming drugs or alcohol to self-medicate. Or they might have a closed head injury, concussive head trauma, and they are consuming drugs or alcohol, or all three. It's very seldom one or the other. Now, there are some patients that are especially high risk in restraint situations and behavioral issues, and when you see these, I want the red flags to go up as far as you need to take extra care. First are the elderly. Elderly people can certainly pack a wallop, but they're very difficult to restrain. In other words, they can punch really hard and they won't hold back. But restraining them, they can break arms, they can break legs, tear shoulders, so on and so forth, very easily due to their overall condition and osteoporosis. So we need to be really careful dealing with them. The morbidly obese, the more they struggle, the more cardiovascular stress they're under, and these patients can code just from that, especially if they're placed prone or in other positions that aggravate their physiological stress. The chronic drug users generally have a history of heart conditions, specifically IV drug users and those who are using cocaine and or stimulants. Even if they aren't using them right then, they tend to have more cardiovascular damage and therefore be more susceptible to unstable angina and stuff. Those who are hyperthermic due to exertion, big red flag for excited delirium, keep that in mind. And finally, those who aren't just mad but delirious. Now remember, delirium and dementia are not the same thing. Dementia is a diagnosis made over months and repeated doctor visits. Delirium is an acute change and is usually due to something besides Alzheimer's or dementia. And withdrawal or drug use is a very common cause of delirium. Now, how do we gauge how combative they are if we want to document it? And we at Ada County, we do not currently use a agitation or violence scale. There are several out there. Maybe we'll use one in the future. But here's an example. This one's used by the Queensland Ambulance Service in Australia, and it gives you an idea. And they usually don't consider sedation unless it's a +2 or +3 on the scale. For those who are just anxious, they usually try to calm them down. Those who are awake or somnolent, so on and so forth, they don't usually touch. Now, how are we going to treat that? Well, one of the big ones is I think we need to remember that we need to remain present and calm. We need to keep in mind that these patients sometimes just want you to listen to them and acknowledge whatever it is that their issue is and just be heard. And that alone can take some of the fight out of them. Now, the issue they may have may be something that you may not normally in the course of your life think is that insurmountable. But remember, these guys are really living at the maximum end of their mental resources to deal with their living situation. So it may be as simple as their dog died, or maybe they're not allowed to see their dog, or their child, or whatever it is. They're mad at their roommate. They don't feel they're getting any resolution. Stuff like that. So when you are listening, engaging with them, avoid seeming like you are dismissing them. And one of the best ways to dismiss somebody is multitasking. If you're looking stuff up, if you're typing on the tablet, if you're writing stuff down instead of making eye contact and verbally acknowledging what they're saying, this can be escalating instead of de-escalating. Watch your body language. Standing over the patient can be intimidating. Don't crowd them if you can avoid it. And if you do have to move into their personal space, let them know first. And what is the tempo and tone of your presence? Keep in mind that as paramedics, we can be really good about saying stuff and not saying stuff. Same thing as, if you've ever been angry at your spouse or your spouse has been angry at you, and you ask your spouse, what's wrong? And they go, fine. We know that it's anything but. They're saying something different than what they're saying. And we can do the same thing, and we need to watch that. Be patient. De-escalation takes time, and if we are used to running call after call after call and getting on scene and off the scene in 15 minutes or less, 10 minutes or less, these are not the calls to be running at that speed and tempo. Slow down. Take your time. Be patient. And a lot of times that can really de-escalate as well. Really be cognizant of how when you interact with the patient that can make things worse. Now, a lot of times when we do things with patients, we're reaching over them, around them, and most patients are fairly tolerant. But again, if they're on the verge of an outburst, a situation like this may actually escalate things. You can tell from looking at this guy, he's not very trusting of the paramedics. The paramedic has his glasses on. The paramedic behind him is reaching around him, crowding his personal space. Probably not making him feel calm. Probably not de-escalating the situation. Okay, I've preached enough about that. Let's talk about actual restraint. So here are some tips for proper restraint. We don't want them to move into a position of self-harm, either purposely or inadvertently. So we don't want them to fall. We don't, be suspended from straps. We don't want them to move down where they're choking on their straps. We absolutely do not want them in a positional dipsnick position, positional asphyxia, such as prone restraint. We don't sandwich them. Sandwiching patients and making them prone makes them quiet real quick, but not in a good way. And if we have IVs and stuff, we want them to not be able to tear those out. Now, a lot of times with IV, sometimes if I don't need a line, I'll just do a lock and then I'll co-band the entire thing. So it's there, I can get to it quickly if I need it to, but they can't necessarily access it without without a lot of work. We don't want them to be able to harm us, so no biting, no clawing, no spitting. If you have the spit hood, use it. Make sure you can still monitor them. Now, there's several things we want you to monitor, such as entitled CO2, if appropriate, pulse oximetry, EKGs, lots of different things. We want to prevent egress, so we'll invert the seat belts. And it's always a good idea that if you have the extra person, to keep them between the patient and the door. A lot of times just having somebody there is a disincentive to try to flee, run, or fight. Now, if the patient is in handcuffs, you absolutely have to have an officer with them, and they have to have a handcuff key for that particular set of handcuffs, especially if they're hobbled. A little example of restraint. So, absolutely, we must not impede the airway or respiratory effort. So again, I just need to stress this again. No prone restraint, no sandwiching, no dogpiling, and no chokeholds. These are all greatly increase the morbidity and mortality of the situation at hand. Now also have a plan, because without a plan it may look a little bit like the old saying about the monkeys in the football, and you may look like this, where the patient's pretty much having his way with the situation and nobody is really doing what they intend to. But this is not the worst case situation. This is more the worst case situation, where it's just a free-for-all. And we don't want this either. This looks bad, somebody's going to get hurt, and the patient's not going to be able to be restrained. Now this is quote-unquote ideal restraint. Again, it's not perfect, but here we have one arm above and one arm below. We have both the patient strapped to a movement device, and we have them strapped over their knees. Now, one couple things I'm not a big fan of on this particular one is we don't have leg straps on this, and I'm not a real big fan of the backboard, honestly, because they can just bash their head against it and injure themselves further. I'd much rather them be on the mattress, but you may or may not have a choice on this. Absolutely, positively, we don't want to see something like this, where we have somebody restrained and somebody's about to put their knee in their back to force them down further. Prone restraint kills patients, and in almost every position paper on the issue of restraint, it's heavily frowned on. So these are the protocols that apply to restraints, and these are our pharmacological agents. Our big ones are benzos, diazepam and midazolam. We also have antipsychotics, Haldol, and we have adjunctive medications, Benadryl. And I want to go back here real quick. It's important to note that we have IV and IM doses for many of these, a max dose of 20 milligrams for diazepam and a max dose of 5 milligrams for midazolam. With Haldol, it's 2.5 to 5 milligrams PRN to a maximum of 10 milligrams, and strongly consider co-administration of Benadryl. Matter of fact, I would just say that unless you have a contraindication, just go ahead and give them both. And Benadryl really helps mediate some of the dystonic and EPS type symptoms. However, keep in mind that Haldol has a lot of adverse interactions with your stimulants, particularly methamphetamine. So I'm not a big fan of Haldol. However, it is in our protocol and is an option for the judicious paramedic. Now, is there a preference? Well, it depends on your situation, and this is not a hard and fast rule, but in general, midazolam, Versed, is better IM than Valium. It's because it's oil-based, so Valium is oil-based, midazolam is not. So therefore, midazolam, if you're giving it in the muscle, it's absorbed much quicker. Valium, however, diazepam, lasts longer and is less sedating than midazolam. So if I have an IV access, I'm going to probably give diazepam instead. Now, it's just me. Every paramedic's different. Haldol works really well with purely psych patients and can sedate the heck out of them. But when you start talking about your stimulants, such as bath salts and methamphetamine, you run into a lot of long-term issues. So how many times do we have an agitated patient that is on a stimulant, even if they have an underlying psych issue? Quite a few. So that's why we have a lot of cautions with Haldol. Now, regardless of the agent you're picking, keep this in mind, is that we use pharmacological agents to make physical restraints safer, not just when physical restraints don't work. So even if we're able to physically restrain somebody and they're still really agitated, even if the physical restraints are holding them, I may still give some benzos to take the fight out of them, because they're going to be safer that way. They're going to not exert themselves as much. They're not going to be as acidotic. They're not going to be as hypercarbic or as hypoxic. They're going to do better. Now, keep in mind, though, that alcohol increases the risk of oversedation. So if you have the drunk combative patient, benzos may be very problematic. So clinical judgment is key. Every agent, I don't care which agent it is, which drug it is, every agent has risk and has a benefit. So make sure you weigh that risk-benefit equation well. Now, invariably, I'm going to get a lot of questions about ketamine. And we discussed this rather heavily in our last standing written orders update. And it is still not currently in our standing written orders. Now, those who like ketamine will talk about a lot of the advantages of ketamine. And we'll probably wonder why. There's plenty of position papers out there right now supporting the use of ketamine in the agitated patient. The bottom line is this, and whether you agree or not, I still would like to see us get ketamine, but I think these are some valid reasons why we are not. So, first of all, there are no great options in chemical restraint. They all carry risk, and ketamine carries some substantial risk based on a large study that was recently done. It has about a 30 to 60% intubation rate at restraint-related doses. Now, the restraint-related doses intramuscular is 5 milligrams per kilogram. That's a heavy dose, but that's the dose at which to effect a rapid sedation. Now, that comes with a price, and that price is the risk. So there was a study that just said that ketamine is not ideal for excited delirium, but beats the alternatives. We're still not going for it here. And the other reason is that the docs queried their fellow physicians, both in the emergency room and up in the ICU where these patients would end up, and there is no consensus on ketamine yet. So realistically, we would be starting a treatment that may not be supported by the physicians we're handing off to yet. I don't think the discussion is over. I think we may still see ketamine in the future for this role. We're just not there yet. If you think it's your only option, you can always call medical control as well. Now, a couple other things to keep in mind: that cardiac monitoring is strongly recommended, even if medications are not given. So, cardiac monitoring does several things. It helps you detect early hyperkalemia from abdomyolysis from their struggle. It helps you monitor their heart rate objectively. And remember, these patients often are under significant cardiac stress. They need at least a minimum 4-lead monitoring. Now remember that when I talk about this, I'm not talking about somebody who's just a little bit agitated. I'm talking about the ones who you're actually restraining and you have to actually intervene on. So, post-restraint monitoring, after you get them restrained, we still want documented every 5 minutes. Every 5 minutes. Consider these high-risk patients. We want your assessments to be focused on hypoxia, so you're going to monitor their respiratory rate, their effort, and their pulse ox. Hyperthermia, so get a temp. Watch their activity. See if it's getting worse. See if it suddenly stops. That's bad. Watch their acidosis and hypercarbia. So again, end-tidal CO2 through a nasal cannula is probably going to be your best option. And watch for cardiovascular collapse. So that's your EKG, your blood pressure, and your heart rate. And finally, because they're restrained, monitor their distal pulse movement sensation. It seems like we're worried about drugs and the morbidity, them dying from their struggle. All that is valid, but also just make note of their distal PMS. Make sure your restraints aren't causing compromise. Now, here are some quotes about documentation. So your documentation at minimum should include clearly articulatable reasons about why you restrained him, not just patient was combative, I tied him up. but patient was agitated with balled up fists, taking swings at the paramedics, screaming incoherently, unable to perform basic assessments, stuff like that. Clear, basic, articulatable reasons. Also document the response to restraints and really demonstrate that you are monitoring him closely, especially if something should go wrong. So finally, looking at some of our pitfalls, things we absolutely do not want you to do. Don't do chokeholds. Ever, period. Don't do them. You may receive patients who are prone from law enforcement. Do not keep them prone. Roll them on their side, restrain them on their side or on their back. If you are injecting medications, watch your sharps. We don't want to stick each other. Now, again, your documentation, make sure you document why you restrained them. If appropriate, make sure you documented ways you tried to resolve the situation without restraint. Paint a clear picture that there was an imminent need for restraint. If there wasn't an imminent need, then maybe they didn't need to be restrained. Be clear and specific and articulatable, objective statements. And also, this is really big, make sure you show that you didn't just restrain them, but you provided medical care while you were restraining the patient. Supplemental oxygen, blow-by oxygen, cooling, whatever the case may be as appropriate. Don't let your documentation reflect that the only thing you did was tie them up, and even though you may have done some other stuff, your documentation needs to reflect that as well. All right, so that's going to be it. Thank you for your time, and be safe out there.